Hi everyone, welcome. Welcome to our live Q&A session with myself and Dr. Michael Green. Today we're going to be answering, or he's going to be answering all of your questions. I'm going to let him start with an introduction, and he's also going to cover a question that's been pre-submitted and a little story for all of you. So Dr. Green, I'll go ahead and hand it to you.
Great. Hi, everyone. My name's Mike Green. I'm an OBGYN, primarily in California, although I have licenses now all over, so I can take care of y'all. Some of you know me from Winona, as I'm maybe your prescribing physician. Others maybe from other Q&As or from some of the material we have on our website. But I'm an OBGYN. I've been doing this since 99, so a long time. I work sort of my day job as an OB hospitalist delivering babies, and then I do this actually has become more of my full-time job. And I also see some patients up in like Arrowhead, California. So anyway, I'm glad you're here. We really want to educate and answer questions. So before I start, what I want you guys to do, if you have questions, start typing them in. So I've got a little monologue here to give you guys a chance to get some questions for me to answer. But also, I like to start off with just sort of something that's either been on my mind or on some of our patients' mind to talk about. And I want to tell a little story, which is actually, it's kind of gross, that happened last night. So I work at a hospital with residents, family practice residents, and so part of my responsibility is to train the residents. And so we did a delivery with a brand new intern. So this is August, last night was August 10th. So this person had been a doctor for a month and 10 days, but he did his first delivery with me. He was really excited. And we got chatting afterwards. And I kind of asked him what he was kind of thinking about doing in medicine. And he started telling me his plan was to sort of open this like alternative medicine clinic and offer all of these treatments. And so I started asking him about them. And it turned out that he didn't really believe that they worked. He goes, oh yeah, this stuff's all baloney. He goes, but you know, it's not going to hurt anybody, and the patients like it, and they pay a lot of money for it. And I'm like, that's really unethical. I mean, if you don't think that this is doing any good, you shouldn't be doing it. That, you know, you don't go into medicine just to like do stuff that doesn't do anything and make money just because it makes money. And the guy dug in, and that's what he's planning on doing. Which one of the nurses overheard when he left. We were kind of chatting about that, but you know, it kind of. Just, you know, I sort of knew intellectually that this stuff is going on, but it really opened my eyes that these people are out there, and it's too bad. I mean, it's what gives us a bad name. And I can assure you that we don't do that at Winona. Everything that we prescribe and that we use has real science behind it, and this stuff works. It's real medication that really works, and this is not placebos. This is not, well, it's not going to hurt anybody, and the patients will be happy, you know, we'll make a lot of money. That is not what we're doing here. And so that's a really important thing to understand, because unfortunately, especially in the sort of internet telehealth space, sometimes it's hard to tell the difference. And to just assure you that I was like horrified, and I'm still sort of grossed out by hearing this from this guy, and to think that there are physicians out there doing that. So I apologize that on the behalf of my profession, but I want to assure you that that's not happening here. The other thing I want to talk about is this concept of estrogen dominance. And I want to be honest with you, that's a trigger word for us OBGYNs. So it's something that when we hear, we kind of shudder, because it's somehow become pervasive in this sort of women's health, particularly perimenopause area. And it's just not a scientific medical term. So this concept of estrogen dominance really doesn't exist in a medical scientific way. If you do a Google search, believe me, I've done it, for estrogen dominance scholarly articles, you'll come up with nothing, because it's not something that's out there in the literature. Now, it doesn't mean that there aren't situations in which women have a predominance of estrogen, either too much estrogen or not enough progesterone, and that can cause problems for people. So there are some situations, there's some really rare things out there. There are these estrogen producing tumors that are incredibly rare. I've actually never seen one in 22 years of practice, but it doesn't mean they're not there. So, but I don't think that's what people are talking about. But that does exist. The more common thing are situations like polycystic ovarian syndrome or PCOS, in which the uterus is seeing more of an estrogen environment than a progesterone environment. And this is an important thing. And it doesn't mean that there's necessarily too much estrogen or not enough progesterone, but there's sort of an imbalance to the estrogen-progesterone ratio. And that can cause problems. And so the uterus, the lining of the uterus, goes through cycles through the menstrual cycle. So you have an estrogen dominant cycle, where there's more estrogen, and that stimulates the inside of the uterus to grow. And that's what happens sort of in the first half of the cycle, getting ready for, in cases fertilized, getting ready for ovulation. And then once ovulation happens, progesterone sort of takes over, and it takes all that tissue that's grown and it organizes it and thins it out and gets it ready for the egg that's supposed to come down. And then when the fertilized egg doesn't come down, both hormones go down, and that's what's caused the menstrual cycle, the period, and that sheds. And so that's sort of the way it's supposed to happen. If instead you don't ever get that time when there's more progesterone than estrogen, that estrogen continues to stimulate and overstimulate the inside of the uterus, and that can cause a lot of problems. It can cause a precancerous situation, or even if left completely unchecked, can be a risk factor for uterine cancer. So that's something that we're very aware of and we're very careful about. And polycystic ovarian syndrome is probably the most common thing that can cause that. It can also be caused by inappropriate medication. So you'll notice that we're always very careful if a patient still has a uterus, if you haven't had a hysterectomy, if we're going to give you estrogen, we're always going to give you progesterone, or make sure you have progesterone to go along with that to avoid this situation. So that's sort of how I think about estrogen dominance in a medically important way. But it seems to have taken a life on its own. I get really interesting questions that don't make sort of a lot of sense medically, that are out there about estrogen dominance causing sort of all kinds of interesting problems. So polycystic ovarian syndrome is a situation with an estrogen, with more estrogen and progesterone affecting the uterus, and for that reason needs to be treated. It can also cause other problems, metabolic problems. It can cause insulin resistance, or at least be part of this syndrome. And so sometimes we give metformin for that, but that's a whole sort of other thing. But the interesting thing about all this is that this all changes as you go through menopause, the menopause transition. So during perimenopause and during this menopause transition, what happens is the ovary becomes less efficient at making hormones. And the ovary is responsible for making estrogen, progesterone, and testosterone. And so the ovary makes less and less hormones. And so those hormones aren't able to affect the tissues like they're supposed to. And that's what causes all these symptoms that women get during the menopause transition. Hormone replacement therapy comes along and replaces what the ovary is not making, getting the hormonal levels back to what they're supposed to be, and sort of rejuvenating the tissues, getting people feeling better, and making you feel like you did, before all this stuff happened. And that's a concept of hormone replacement therapy. So even women that had PCOS at one time, or had, more estrogen than progesterone for whatever reason, as the ovaries start producing less and less hormone, they're going to need replacement of both. And so it's a misnomer to think, gee, in your 20s, or even your 30s, you had, polycystic ovarian syndrome, and it was causing problems. Maybe you had a hard time getting pregnant, or it was causing facial hair or obesity or other issues. But as you go through that perimenopause period, those hormones start dropping, and they need to be replaced, both estrogen and progesterone. So as much as I can piece together, that's how I understand this concept of estrogen dominance. Because again, it's not something that is in the medical literature, but that's the way I understand it, and it really sort of becomes a moot point once you start going through the menopause transition, because now you're deficient in all your hormones, estrogen, progesterone, and testosterone, and they all need to be replaced. And even if one is dominant over the other, if there's not enough of any of it, it doesn't matter. They all need to be replaced to get everything in balance. So I hope that helps. I hope it doesn't alienate anybody, and I'm happy to field follow-up questions on that. try to explain it as best I can. So it looks like we've got a few questions now. So I guess I stalled long enough so we can start answering your questions instead of mine.
Yes, you have quite a bit. The first question is there a strength for the HRT lotion prescription?
So there are several strengths, and it sort of depends on your situation as to what strength we start with. I have an algorithm that I've built over thousands of patients that puts together your symptoms, your history, sort of, some other things, what medications are on, things like this. And then from all this information, it comes up with not only a recommendation for what type of hormone replacement therapy is going to be best for you, but also gives us an idea of what strength to start with. I've purposely gone on the lower side. There's always a range, and I always choose the lower side of the range because if I'm going to miss, I'd rather miss too low than too high. So I'd rather you come back in 10 weeks and tell me, it's not really tackling my symptoms like I'd like it to. And then I can say, well, let's increase this a little bit and try and get you to the right level of medication that's going to fix your symptoms. Then overshoot and give you too much medicine, and then you're like, I'm having these side effects because I overshot and I gave you too much hormone. So I do have an algorithm that comes up with the strength. It helps guide us, me and the other physicians. Sometimes we'll change that based on some other subtle things that we see. But again, occasionally I overshoot, not very often. Usually I hit it right on, but if I'm going to miss, it's usually that it's a little low, and then we just need to increase it a little bit as we go down. But there are varying strengths sort of depending on your situation.
The next question is from Linda. Hi, how do you recommend transitioning from my current DHRT provider to Winona?
So it sort of depends on how you're getting it. If you're going, for instance, from cream to cream, just transitioning from one to the other is really simple and it works fine. If you're changing modalities, if you're going from a patch or a pill to a cream, I like to keep the old one on board for a week or two because it does take the cream a little while to get blood levels up and to really start working. And so for me, if you're on a patch or a pill and you have enough, I would recommend using that for the first week or two that you're using the cream, and then withdrawing the old hormone replacement therapy. It makes it a little bit easier transition. It's fine to go from one to the other, but you may have a week or two where you're a little uncomfortable with symptoms. It's not dangerous, but it can be a little uncomfortable. So that's the way I like to do it. I know some of the other doctors don't do it that way. They just go straight from one to the other. And like I said, that's safe and it's a reasonable way to do it. I just think it's a little gentler to sort of have a little bit of an overlap. That's sort of the art of medicine.
The next question is from Renata. What is the highest dosage of estrogen available? I understand doses are based on the individual and should be determined by your physician.
I love your little caveat. You sound like a lawyer there with the little asterisks. Results may vary. I'm teasing, but no, I get it. That's a great question. So the highest dose of the pill commercially available is 2 milligrams, but I've got people on taking 2 of those a day if needed. So sometimes, it takes a lot of estrogen to get people comfortable. The highest dose of estrogen in the cream that we have is 7.5 milligrams per ml. We actually had a 10 milligram cream, but the consistency was off and it would flake out, and it just seemed like we were trying to shove too much medicine in that amount of cream. And so we backed off because it just didn't seem to be a very effective compound. And so we use 7.5 as our highest per ml. But you can use, a larger volume of cream to get more estrogen if necessary. And then as far as a patch goes, the 0.1 milligram is the highest dose patch that it goes to. And for women in particular, women that have undergone what's called surgical menopause, that's where they've had both ovaries removed surgically, tend to require a lot of estrogen because instead of going through perimenopause gradually over 7-10 years, they go through it overnight. And so it can take a lot of estrogen to get through those symptoms and get you feeling human again because of that sudden drop of estrogen. For those women, we tend to have to push the dose. Those are the people that maybe we have on, 2 of the 2 milligram tabs, or we have them taking 3 or 4 pumps of the 7.5 milligram cream or something like that. But those are the highest doses available. just from a practical point of view, either what's commercially available or the most medicine we kind of shove in a volume of cream, and it still be a reasonable consistency.
Next question is from Amy. What time of the day should you take DHEA supplement?
So for most people, the DHEA can be taken any time of the day. And so I recommend taking it whenever is going to be the easiest for you to remember. So I take medication for my blood pressure. I take it in the morning. I have my little pill thing sitting with my deodorant because I never forget to put deodorant on in the morning. And when I reach for my deodorant, it's like, oh, I gotta take my pills. So that's how I remember to do it. So I always recommend kind of tagging your medication with something that you're already doing every day because it helps you remember. So for most people, the DHEA, whenever it's easiest to remember, is the best time to do it because consistency is going to be the most important. I have found there's a huge range in response to DHEA. I've had some people tell me that it makes them really sleepy, and then it's like, okay, well, take it at night, and then they're happy. And I have other people, it keeps them up. Okay, take it in the morning. But for most people, it seems to be okay any time of the day. It sort of has much less of an effect on, causing drowsiness or causing alertness than, say, the progesterone in the cream would.
Okay, our next question is from Jamie. I'm in my mid-40s and just started experiencing night sweats in the last couple of weeks. Help! Should I plan to start HRT right away or wait until I've had symptoms for a longer period of time?
So if that's your only symptom, it may or may not be perimenopause. There are other things that can cause hot flashes or night sweats. Maybe you got a little cold going and you didn't realize it, or if you just got your COVID booster. I know that's I had those all night long. So if it's just for a few weeks and that's the only symptom you have, you might wait it out and see if it goes away. But I wouldn't wait too long. There's really no reason if you're having symptoms not to start hormone replacement therapy and feel better. The big number is 60. So as long as you started before age 60, it's going to be safe. I mean, assuming you don't have other medical problems. Yeah. So the thing is, there isn't sort of an expiration date. It's not like, okay, I've got 5 years of HRT, so I've got to time this right. The average woman is on hormone replacement therapy for 5 years, but there are some women that are on it their whole life or for a very long period of time. There's others that may only need it for a year or two. So you can use this as long as necessary. So once you've sort of determined that these night sweats that you're having really are perimenopause night sweats, and they're uncomfortable enough for you that you want to get rid of them, then you might as well start hormone replacement therapy now and feel better. No point suffering and putting it off. My wife and I, we sort of have this little deal at home. Neither of us are really allowed to complain about having a headache until we've taken like Tylenol or ibuprofen for our headache and it hasn't gotten better. So it's like, well, did you take Tylenol? Yes. Okay. I feel bad for you. It's like, no. Okay. Well, take Tylenol. And so if you're having symptoms that are bothering you and there's a treatment for it, use the treatment, feel better. I mean, thank goodness we live in the 21st century where there's ways to take care of these things. Instead of having to go out and find the right roots to chew on, it's nice that, there's a convenient way to do this and feel better.
The next question is from Sally Ann. I do have a concern on the manufacturer of the medication. I've read some on contaminated meds with other drugs. How can you guarantee the pureness of the medicine?
So the creams are easy. We make them ourselves. So the creams are compounded in our pharmacy by our pharmacists. I know these guys. These are some of the smartest guys I know. There have been problems. I'll be honest with you. There's issues with compounding pharmacies, and the FDA is actually looking at this right now. The North American Menopause Society just came out with a statement saying that they can't recommend compounded medications, and the reason is that there's a lot of variation between the quality and the purity of the medications depending on the pharmacies. So compounding pharmacies, there's really good compounding pharmacies and there's not really good compounding pharmacies. And so you want to make sure that you've got a high quality compounding pharmacy. You've got people that know what they're doing and that are ethical and making sure that they're really giving you a good product. I can tell you that our pharmacies are great. Our pharmacists are amazing. They're some of the smartest guys. They've been doing this. The pharmacy itself has been in practice for generations, actually. There's a huge, long track record here. And so for our compounded medications, which is really the biggest thing that you worry about, I can, I'm staking my license and my reputation on this. The medications are pure and good, and they have what we say they have in it. In fact, I just had a conversation with a patient today. We don't compound DHEA, and the reason we don't is that our compounding pharmacists tell us that it doesn't absorb well, and it's more of a placebo than anything else. They said, yeah, sure, we can make it, and there are doctors that sort of insist we make it for them, but the truth is it doesn't really work. And so we don't offer compounded DHEA for that reason. And so we're very careful that way. So as far as the compounded medicines, which really is where the issue is, I can tell you, and it's as good, I guess, as my word, that our pharmacy is really high quality and top notch, and we're very careful to put out, a quality, good product. The DHEA would be the sort of the second thing, because it's not a FDA regulated pharmaceutical, it's a supplement, and supplements can vary. And so again, that's another thing we're very careful about. We actually have gotten to the point now that we're big enough that we can, we have a company that's making the DHA specifically for us. I can tell you, and some of you may have noticed this, we did have a little problem because the batch they're making right now took a little bit extra time because they want to make sure it's right, and they're held up in testing to prove to us and to themselves that it is what they say it is. And we had to do a little scramble. We found a reputable place to get some DHA right now, which is why the current capsules are a little bigger than the ones we usually use. But we do, fortunately, we've grown enough that we have enough say that we can sort of demand the product that we need and make sure that it's pure. And then the other medications, the progesterone pills and the patches, they're really generic retail medications, and they're sourced from large manufacturing sources that are under very strict FDA scrutiny. So I can tell you, all three sort of categories of what we sell and what we send you are top quality and pure, and they have in it what they say they have in it.
Our next question is from Stephanie. I started taking DHEA and using my cream about 2 weeks ago. I fall asleep as soon as my head hits the pillow, but then am restless all night with weird dreams. Does this stop, or do I need to change my dosage?
So instead of changing your dosage, I would try taking it in the morning. The progesterone in the cream, it's most likely the progesterone in the cream, although as I kind of talked about before, it could be the DHEA, although that's less likely. So I would try taking it in the morning and see what happens. It's a small percentage of people. For most people, the cream, particularly the progesterone in the cream, helps with sleep. It helps with deeper sleep and more restful sleep. But every now and then, it gets more activating, and it can cause more restlessness, insomnia, or even weird dreams. And the cure to that is to take it in the morning. It can have a caffeine-like effect on some people. So try switching the cream to the morning, see if that helps. If that's not the issue, then try moving the DHEA. It's totally okay to kind of experiment around and see what works best for your body. One of the crazy things that I've learned in medicine is how unique each individual is. We actually learned that the very first thing we do in medical school is gross anatomy, where we dissect our cadavers and we learn like all the parts. And it's a huge warehouse with basically all these cadavers, and there's a team of medical students at each one. In our school is like 4 per cadaver. But we also go around and look at everybody else's specimens because there's a lot of variation. There's an incredible amount of variation in the way the human body is from person to person, not just in sort of size and looks, but even how many blood vessels go to this thing, or where things go from one thing to the other. It's very, very interesting how different everybody is. And that works out physiologically and the way people respond to medications as well. So there's a huge variation in the way anyone will, any individual will respond to any given medication. We sort of know on principle and on average what the majority of the population does, but not everybody's body reads the textbook, and sometimes their bodies do different things. So it's totally okay to experiment with different times of day to take these medications, see what works best for you, and find the routine that works best for you. That's completely appropriate, and I think a smart way of doing that. So first thing I would try the cream in the morning and see how that works for you. If you find it's too sedating, another thing to try would be a split dose. So you could do, a pump in the morning and a pump at night, or different times of the day that way. So there's different ways to sort of mess with this and make it work for you. Go ahead and personalize it though. There's nothing wrong with that.
Our next question is from Maricela. Do you recommend these products for postmenopause?
If you're having symptoms, yes. Again, 60 is a magic age, so you need to be less than 60 to start the medications to do this safely. But if you're, basically the definition of menopause is you've gone 12 months without a period. So once that hits, then the day after that, you're postmenopausal. But if you're still having symptoms, this works very well for a postmenopausal woman, just like it does with a perimenopausal woman. Now, sometimes some of the symptoms tend to go away with time, like hot flashes, for instance, and sometimes even the sleep disruptions. But some of them get worse. And so if, the skin changes, the vaginal changes, those things can get worse with time, even postmenopause. So if you're having symptoms, yes, and you're under 60, it's a very safe way to do this and still can improve your symptoms. The idea here is to get you feeling better. And if you're not feeling good and these medicines make you feel better, life's too short not to feel well. So I think it's a reasonable thing to do.
Okay, our next question is from Jennifer. I have had a lot of breast swelling and some burning in them since I started my treatment a few weeks ago. Is that normal?
So it can be. Breast swelling is one of the occasional side effects that happen particularly with the estrogen part of the hormone replacement therapy. For most people, it's a short side effect. So it sort of starts right away because the body doesn't like a sudden change in its environment, and all of a sudden it's getting these hormones it wasn't used to. That sort of levels out and you get a new normal, and then those side effects go away. One of the frustrating things about this, quite honestly, is that the side effects tend to come on fairly quickly because they're generally caused by a change in hormone levels. And so you go from low hormones to normal hormones, but that change from low to normal, the body doesn't like change. And so it can throw off side effects and cause some problems. And that usually only happens in the first few weeks to a month or so. And then the body sort of adjusts to the new normal. Then those side effects go away. The benefits actually tend to take longer because first you've got to get that change to that steady state drug level, and then that drug level has to start affecting tissues. So one of the frustrating things about this is that the side effects come on first, right when you're all excited about having benefits. And so you're having all these side effects like breast tenderness, but you're not getting the benefits. You're like, why am I doing this? But if you stick with it, the side effects tend to go away and then the benefits start showing up. Now, every once in a while, breast tenderness can mean that your dose of estrogen is too high. And so if that doesn't go away, in the first few weeks to a month, it may be that we need to adjust the dose down a little bit, because that can be a sign that the dose may be high. But it sounds like you recently started this. I would hold off for a couple of weeks and see what happens. If you told me you'd been on this for 2 months and your breasts are still tender, we probably overshot the estrogen a little bit, and we probably need to decrease the dose for you. But if it's really just still in the first few weeks, I think there's a pretty good chance that's going to go away, and you're going to start feeling better, and you're going to get those symptoms resolved.
The next question is from Melanie. Why don't general physicians know more about menopause symptoms? It seems like the response is to take antidepressants or to ignore the symptoms as normal.
Yeah, and this is really, the answer really is history. And so, what happened, so, I'm like an old doctor. So I got out of residency in 99. And back then, we were giving hormone replacement therapy to everybody. We thought it was a vitamin. Like, no, nothing bad about it, only good, give it to everybody. We were giving it to, 80-year-olds. And quite frankly, we were overriding it. And, but that's what the data said at the time. And then the Women's Health Initiative study came out, which was honestly not the greatest study, but it was a huge study, and it turned everything upside down. And basically the outcome of that study was, hey, this isn't a vitamin. This has risks like every other medicine, and you got to kind of count the costs. Unfortunately, with that study, they were using hormone replacement therapy like we were in the old days, giving it to 75, 80-year-old ladies. And those women were having problems. And so it looked like HRT was a lot more dangerous than it was. And so over the years, the pendulum sort of swung from everybody on HRT, and then like overnight, like the phone was ringing off the hook. Everyone was stopping their hormone replacement. Everyone was scared to death of giving it. The doctors were scared of giving it, and everyone stopped prescribing hormone replacement therapy. And that happened for a while. And then the data started trickling out, and people started looking at this study more carefully, including some of the authors of the study came out sort of several years later saying, whoa, people, you're making a mistake here. And it turns out that if you're careful about how you prescribe it, and you don't give it to people that are over 60, for the first time, you don't give it to people with a history of heart attack or stroke and, these other problems that, medical problems, but you basically give it to younger, healthier people, it's actually incredibly safe and very effective. And so the pendulum is just now starting to swing back the other way. It's not going to get back to the crazy time where we're giving it to like everybody and handing it out, like vitamins, and it shouldn't. But it's starting to move a little bit, I think, to a more healthy place where there are a reasonable amount of people that have realized that this is safe and helpful for people and we should be prescribing it. Unfortunately, so I'll tell you a story. I was in the operating room. This is 2-3 weeks ago. So we had a great problem to have a little while ago. We grew 50% in a month at Winona, which is like a great problem to have. But I sort of got caught flat-footed, and I hadn't hired enough doctors, and so I was working like crazy, seeing all these extra patients. So I've been recruiting doctors, hiring more doctors, because fortunately we've been successful with this. And so I was in the operating room and I was talking to one of the docs. He's a good doc, and I was asking her if she would be interested in being a Winona physician, kind of a side job that she could do while she, did her regular practice. We were doing a C-section together. And she's like, I wouldn't know how to prescribe hormone replacement therapy. She goes, when I was in residency, they said, you know what, you got enough to learn. You're never going to be given this anymore. So just forget about it. And so all these people for this big chunk of time never got trained in it, because at that time it was sort of scary and nobody was writing it. And it's like, yeah, don't learn this. You got plenty of things to learn. You're not going to be using this anyway. This is stuff that they used to use in the old days. So there's all these people out there, even OBGYNs, that aren't comfortable prescribing HRT, and quite frankly don't know how to, because it's something that they never learned. And that's a problem. I mean, I can tell you I have a lot of patients that come to us, and what they tell me is that, their doctor just blew them off and said, I don't prescribe hormones. And that's a shame. It's because it's something that is beneficial for people. It needs to be done correctly. But when done carefully and correctly, it's a very safe medication and makes a big difference in quality of life. So it's not that your doctor is a bad doctor or not a smart doctor. It's just that they were trained at a time when nobody thought this was ever going to come back. And so there was no point in learning this stuff. And so, it's been a problem. But fortunately, like I said, the pendulum, I think, is starting to swing back a little bit, and people are starting to be able to get their hormone replacement therapy. We've come in, and other companies like us, as well as a lot of private doctors, and realizing this is something that, is important for women and should be offered.
Jamie is asking, if you have a Mirena IUD, is there a customized HRT plan you recommend?
So that's a great question, and it's controversial even among the Winona doctors. And here's the reason. So in theory, the progesterone in the Mirena will protect your uterus from the estrogen in the hormone replacement therapy. When we give hormone replacement therapy, generally we're talking about estrogen. If you have a uterus, as I talked about earlier, you need progesterone to protect the lining of the uterus against the estrogen. Pardon me. And that's the main reason that we prescribe progesterone. Progesterone is beneficial for other things. It can help with sleep. It can help with mood stabilization, but it's sort of a secondary thing. And most of the time, the progesterone is really prescribed to protect that lining of the uterus from getting a uterine cancer from having only estrogen. Now, in theory, if you have a Mirena and it's still active, it's putting out enough progesterone to protect the lining of the uterus. So one way to do hormone replacement therapy in somebody with a Mirena is to prescribe only estrogen and rely on the Mirena for the progesterone. And so several of my colleagues, several of the Winona docs do it that way, which is fine. It's a completely reasonable way to do it. I personally don't feel comfortable doing it that way. And the reason is, in a way, because I don't own your Mirena. So I don't really know how long it's been in. I may not know if it comes out or if you had it taken out. You may not realize to tell me that, and I don't want to hurt you. So the first rule of medicine, they say first do no harm. And that's been my philosophy when we built Winona. Is the first thing is I don't want to hurt anybody. Safety, safety, safety is the most important thing. And I know that if I give you estrogen without progesterone, I potentially could hurt you if you have a uterus. Now, if you have that Mirena, you're really protected, but I'm worried because I'm not seeing you in person. I'm sort of not responsible for all of your gynecologic needs and your birth control needs and that kind of thing. So I don't really know what's going on. I don't know how long has it been in. Is it still putting out enough progesterone? Has it come out? And so for me, I feel more comfortable giving you both estrogen and progesterone. It helps me sleep at night knowing I don't have to worry that I haven't hurt you. But it's completely reasonable to do it the other way also. As the chief medical officer of Winona, and I've been in leadership position sort of most of my career. So my job as an OB hospitalist, I'm the site director. I'm in charge of the doctors in the hospital that I work. I was in practice in Ventura for 17 years, and I was the chief of OB for our clinic system, and I hired and fired the doctors there. And my feeling has always been, I let the doctors practice medicine the way they feel comfortable practicing medicine. In some systems, the guy in charge tells everybody how they have to do it. And I don't do that. It's like I hired these people because they're good doctors and I trust them. And we all have our own style, and it may be a little bit different. As long as it's safe, it's a reasonable way to go. So for me, if you're a California patient and I'm seeing you, and you have a Mirena, I'm going to give you progesterone. If you're a Texas patient and Dr. Davis is seeing you, he may not do that. So it depends on which doctor you get. They'll have our own style and our own theories about this, and I think there's a reasonable argument both ways.
Shani is thanking you for your explanation on estrogen dominance. It was a lot of help. Sally Ann, in the past I have tried HRT through my regular doctor. After around 3 months, I had extreme emotional outbursts, which made me stop using HRT. I am now 57 and postmenopausal. I still have hot flashes, now brain fog, weight gain, fatigue, insomnia. What side effects, if any, does this medication cause?
So to start with the beginning of your question, I don't know exactly what type of HRT you were on. The bioidentical forms of HRT, I think, tend to have less side effects than the synthetic forms or the horse-derived forms. And so I don't know whether you were on a bioidentical hormone replacement therapy regime in the past or not. I also don't know what kind of dosage you were getting. It's possible that you had, you were overdosed or underdosed and it wasn't controlling things correctly. Also, again, I don't know how long in the past, but the body changes over time. And I can tell you, in my life, I found that things that affected me poorly 10 years ago may not affect me poorly now, and things that I could do 10 years ago, I can't really get away with anymore. And so as we age, things change in the way it affects our body. So just because you had a bad experience in the past doesn't necessarily mean you're going to have a bad experience again. And it may be a matter of dosage, it may be a matter of bioidentical hormone, or maybe a matter that your body has just changed over time, and it may tolerate it better. The most common side effects for hormone replacement therapy, there are initially that first month. Sometimes women, it'll throw off a period the first month. Should not be an ongoing thing, and if people have irregular bleeding beyond that, that can be a little concerning. But that first month, sometimes it'll throw off an irregular period or have some spotting, and that's fairly normal. The estrogen can cause some breast tenderness. We sort of covered that already. Sometimes the DHEA can cause a little acne breakout. Really at first, that once that sort of clears up, it usually goes away and we don't see that coming back. Occasionally there can be some nausea. Usually the body gets used to that and it goes away. And occasionally some constipation. Also, sometimes we see some water retention at the beginning of treatment, or some bloating. The bloating can be from the water retention, or it can be from constipation. But those are usually short-lived. And so for most people, they don't have any of that stuff. But for some people, that first month can be a little rocky. And once they get through that month, those things usually fade away and the benefits really start coming on. So, again, specifically to you, whether it's going to cause, an emotional problem 3 months down the line, I kind of doubt it. I think that most likely that had to do either with a dosing issue or with the type of hormones being used. Anything's possible. And as I said earlier, we're all unique, and you can't really predict how any individual is going to respond to any medication. But for most people, it actually is mood stabilizing and helps with the emotions and sort of helps, bring things, under more control that way.
Next question is from Christina. What do you recommend for clitoral atrophy?
Great question. It sort of depends on what's causing that. So there's two really main things. One is lack of estrogen in the vaginal area. The other is something called lichen sclerosus. So if it's lack of estrogen, then estrogen replacement is going to help that. The creams, patches, and pills will help that, but it can take a very long time. Vaginal estrogen cream is going to work a lot more quickly and maybe more effectively. However, if it's not from lack of estrogen and it's something called lichen sclerosus, estrogen replacement is not really going to help that. And in that case, a high potency steroid topically can really help a lot. That's a diagnosis that needs to be made in person, usually with a biopsy. You can see and usually get a pretty good idea by looking, but you usually need a biopsy to be sure. And so I think it'd be reasonable to try estrogen, but if it doesn't fix it, fairly quickly, it's probably worth going in and getting an exam to see if it's this other thing or something else. So again, there's different things that can cause that. But it's reasonable, I think, to try some estrogen and see if that helps. If it does, okay, there's your answer. And if not, then really go in. You're going to need to go in person and have someone take a look at that.
Courtney said, I love my cream and DHEA I've been using for the past 2 months. Most of my symptoms are gone: insomnia, hot flashes, tired, aches. The only ones that are not is my thinning hair falling out. I had COVID in February and have been told shedding can happen for up to a year later, and my inability to lose weight. I've actually gained weight. I'm going to touch on.
Okay, so let's tackle the hair first. There's something called telogen arrest. And that typically happens 3 to 6 months after a stressful event. So if you had COVID in February, we're right about on the right track for that. And telogen arrest is a really scary phenomenon. I know this well because I had it as a kid. I was in a really horrific car accident. Someone fell asleep on the road and knocked my brother and I off a mountain. I was in the intensive care unit and hospital for months. I lost like the last half of my senior year, but I'm all good now. But about 6 months later, all my hair started falling out and I panicked. And so went to the dermatologist and they looked at me and said, oh, it's telogen arrest. And then they explained it to me. And so this kind of got cemented in my mind. And so what happens is the hair is on a cycle. And so you have new hair growing, you have hair getting old, you have hair sort of just doing nothing, and then you have hair falling out. And when you get into a stressful situation, it sort of shocks the hair follicles and it just stops. It arrests in the telogen phase. And then once you get through that, things start cycling again, but you have all this hair that was in the same phase and it all cycles into the fallout phase at the same time. And that's why for 3, 4, 6 months after a stressful event, all of a sudden it seems like all your hair is falling out because it is. But then it gets back on cycle, things start kind of, fixing itself out and your hair goes back to normal. So that's very common with something like COVID, or we see it in women after having a baby. We see it in 17-year-old high school kids that get in terrible car accidents. It's a pretty common thing. And so that's one possibility of what's going on. There are a lot of other things that can cause hair thinning. Hormone replacement therapy in general increases the thickness of the hair and the quality of the hair. And so it really shouldn't be causing that. DHEA, if you look it up, it's going to scare you to death because unfortunately, for what it's worth, there are people that take huge quantities of DHEA. I used to do a lot of powerlifting. My hands kind of got messed up, so now I don't do as much powerlifting. But I'm in the gym a lot, and I've got some big friends that are on testosterone and whatnot, and some of them take really high quantities of DHEA for the testosterone benefit. And in those really high quantities that people take, it definitely can cause what they call androgenic side effects. It can give you male pattern baldness and acne and all these things because the testosterone levels get so high. But in 25 to 50 milligrams that I prescribe, it's not going to do that. And so even though if you look up on the internet, you'll see that that's a side effect of the DHEA, it's really unlikely in 25 to 50 milligram dose. We're talking 200 milligram dosage a day or more is what some of these guys are using, guys and gals. So I don't think it's coming. I don't think the hair thinning is coming from your hormones. My guess is it may have something to do with the COVID in February, but that's going to be a wait and see. But if it keeps becoming a problem, a dermatologist, they're the type of doctor that you want to see for hair problems. So if it continues to be a problem, I would make an appointment with a dermatologist and see what's going on, and they can probably help you with that and get you on the road to fixing your hair. The weight loss is another issue. And so you're 2 months in, if I remember right, and weight loss can take a while. So the DHEA and the cream does help change some of the metabolic properties and get some of that particularly central weight off, get it out of the tummy and redistribute it or even move it away. The DHEA in particular, again, it's why they use it in the gym, can help with your muscle mass. And as you build muscle mass, your pounds may not go down, but your lean body mass can decrease. You may also still lose weight, but remember, muscle weighs more than fat. Muscle also costs more to keep up. So if you have more muscle, you burn more calories just sitting around doing nothing. So a big muscular person watching TV is burning a lot more calories than a skinny little person or somebody that's just got a bunch of fat. Because muscle burns calories even at rest. And so the DHEA helps increase muscle mass, which is sort of a cycle that helps increase your basal metabolic rate, the amount of calories you burn at rest, which helps you lose weight as well. Those metabolic changes take time though. So first we've got to get drug levels up, and then you've got to start getting these metabolic changes, and then they've got to take effect. I found that 3 months is the normal mark when people really start noticing a difference. Some people get lucky and they notice it a lot earlier than that. Some people are not so lucky and it takes longer. And for some people, it doesn't really work for. But that 3 month mark to me is sort of the critical mark. If you're not starting to turn the corner at the 3 month mark, it may be time to increase the DHEA. And then the other thing is that hormone changes in menopause is one part of the whole weight gain, weight loss picture. It's a very complicated thing. It also has to do with our diet, it has to do with exercise, it has to do with stress levels, it has to do with your thyroid. There are other things that can affect your metabolism that can also affect whether or not you lose weight. And so we want to maximize the hormone change part of it, get your hormones back to where they should be, get your testosterone, your estrogen, your progesterone levels where they ought to be with hormone replacement therapy. And so maximize that part. And that takes that part away from the weight loss. And if that's what's been holding you back, it's going to help. You're going to lose weight. You're going to increase your muscle mass. You're going to redistribute your weight so you look, you have more of an hourglass than a pear shape, which is what most people, strive for. But there may be other issues going on. There can be dietary issues. There can be mobility issues, exercise issues. Maybe there's a thyroid issue. So those are all things to think about. People often tell me, well, I'm eating clean. That's great. That's healthy for you. But, you can eat a lot of calories on a clean diet. And so just eating clean doesn't necessarily fix the problem. You really got to look at your caloric intake. You want to make sure you're eating enough protein because you need that protein to build the muscle. And you want to, minimize your calories while maximizing your protein intake is really sort of the best way to do it. So there's sort of a lot that goes into weight loss. It's not that simple. The hormone changes in perimenopause is absolutely part of it and can all of a sudden change things so that everything was going fine and then all of a sudden, boom, they're not. And we fix that by fixing those hormones back to the way they were, and you're back on track like you were before. And that happens for a lot of women. But for some people, that's not the only thing going on. So anyway, at 2 months, I wouldn't give up on the weight loss part. I think there's still a chance it's going to kick in. And we can still, increase the DHEA if necessary and maybe get you to where we need to get you. But I'd also start looking at other parts of your life.
You touched on this a little, but Renata asked, is it the HRT or the DHEA that helps with hair loss?
It's primarily the HRT. So yeah, it's the estrogen in particular that more likely than either the progesterone or the DHEA is going to help with hair thickening and also, like I said, healthy hair.
Elizabeth asked, the only thing that's a little off, but my right hand middle finger gets really sore when I use the cream on that side of my forearm. It's very bizarre. What could this be caused from? It only happens if I use the cream. My fingers feel weird. Not sure why this is happening.
Neither am I, quite honestly. I'm not saying it's not happening because it obviously is. So I don't want to invalidate what's happening. I don't have a great explanation for it. What I would recommend is try mixing it up a bit. Try not using your middle finger for a while. Just use maybe your index and your thumb, or I don't know, however you can do to get it on, or use your other hand. I'm right-handed, so and I'm very right-handed, so I know it'd be a little weird to rub something on with my left hand, but try using your left hand for a while and see if that sort of heals up. Something in the cream is obviously annoying your finger, and it's probably that finger is getting the majority of the cream. And so, try using a different method. Another thing you could do is pump the cream directly on your wrist and rub your wrist together. That eliminates your fingers altogether. So that would be another strategy. But, be creative and try and come up with ways to give that finger a break and see if that solves the problem. That's the first time I've heard that. I agree, it's weird, but doesn't mean you're weird. As I said, each body is unique, and it's always interesting. I know, here's a rule of medicine: you never want to be an interesting patient, but it is kind of an interesting thing that I haven't really heard before.
Okay, so Mary said, how will I know if I need DHEA supplements? I am generally confused about what I need and how much.
So it really has to do with your symptoms. In general, most people that are going through the menopause transition are going to need some of all the hormones, because again, the ovary is responsible for making estrogen, progesterone, and testosterone. And as the ovary becomes less efficient and less productive, those hormones drop. DHEA gets broken down into estrogen and testosterone. The estrogen component, honestly, is pretty small, but it's a testosterone component that we're after. And that sometimes it's testosterone, that's the male hormone, but it's important for women also. Certainly, unless you're trying to, become a bodybuilder or, competitive athlete, you don't want to use sort of huge levels of testosterone, but there is a normal level of testosterone that women are supposed to have that keep their body healthy. And that's what the DHEA does. It's a nice way. The nice thing about DHEA, as opposed to say testosterone cream, is that at 25 to 50 milligrams of DHEA, we're not going to push you outside of the normal realm of testosterone. We're going to really get you right down into normal or maybe low normal levels of, female levels of testosterone, which is really right where you want to be. So it's a very safe, it's kind of an easy, gentle way of doing it, but it gives you that benefit without overshooting, and then you start getting the testosterone side effects that most people don't want, which would be, male pattern baldness, acne, deepening voice, those kind of things. So that's where the DHEA comes in. And then usually people need estrogen and sometimes progesterone as well. So the nice thing about hiring me is that you don't need to know what you need. You can tell me what's going on and I can recommend it for you. How are we doing on time? Can I tell another story?
It's 5:27.
Huh?
It's 5:27.
Okay. You guys want a story or you want me to answer more questions? I'll tell the story. So years ago, we had a doctor that we had to fire. So I went to the hospital VP and I let them know. And they were really afraid they were going to get sued and all this stuff. So we hired an attorney and to say, hey, what's the right way to do this? And then the attorney gave us advice, and I'm like, okay, we'll do that. And then the VP, who was also an obstetrician, by the way, I don't know if we should do it that way. I said, Richard, I'm like, we just hired this expert to tell us how to do it. We should probably do it that way. I'm like, don't you hate when patients come into your office and you give them sound advice and they say, oh no, I don't think I want to do it that way. And so it's kind of a lesson, like you hire an expert and, it's probably a good idea to take the expert's opinion. So it doesn't mean you want to follow blindly, but pick my brain, I'm a resource. You're hiring me basically to help you and guide you and give you advice. And hopefully, the idea of a doctor-patient relationship is that we develop a trust, that I'm really out for your best interest, and I supposedly know what I'm talking about. And again, you don't want to just blindly follow me, but you do want to listen to my advice, and do your own research is fine, but you don't really have to know exactly all the ins and outs of how to do it. That's what you're hiring me for.
Tina said, I was diagnosed with stage 3 rectal cancer last year. I had chemo followed by chemo radiation, followed by surgery 2 weeks ago to remove the cancer along with a complete hysterectomy. What hormone replacements would you recommend for me now that I'm in surgical menopause?
Yeah, you're not going to like my answer. The right answer on the test is that hormone replacement therapy is probably safe for you. But I can tell you that I would not feel comfortable prescribing it for you on our platform. And the reason is that once you have one kind of cancer, you're at more risk for other types of cancers. And as I said earlier, my first principle is do no harm, safety, safety, safety. And although we do develop a doctor-patient relationship and we get to know each other to some extent, it's not going to be as thorough as an office practice. And so patients that have significant medical problems that theoretically could put them at risk, I don't feel comfortable in this situation prescribing these medications to you. So this is something that I would encourage you to see your doctor about, talk to your oncologist and your OBGYN. You must have had someone did your hysterectomy, and talk to them about hormone replacement therapy, whether they think it's safe for you. They've been inside of you, they've seen where the cancer was, and they're going to have a better idea of whether this is the right thing for you. Just based on what you're saying, yeah, if this was the information I had and I was taking my board exam, I'd say, yes, you're a reasonable candidate. But I just think it makes me nervous. And again, the last thing I want to do is hurt anybody. I'd rather say no and not risk harming than rolling the dice and taking a risk. That's not a good way to do medicine. So talk to your docs. I mean, you've got a gynecologist, somebody did your hysterectomy, you've got an oncologist. They know your history, and they can make a much better recommendation than I can.
The next question is from Amy. Do you also offer TRT?
You're talking about thyroid replacement or testosterone replacement? We don't do either. So I think you're talking about testosterone replacement. People use those initials for different things. Here's the thing about testosterone. Okay. So here's the thing about testosterone is it's a controlled substance. So we can't do it with the type of telehealth that we do. You need an in-person visit in most states. Truth is, right now with some of the COVID rules, there are workarounds, but we sort of made a strategic decision not to use the COVID rules for our telehealth. And the reason is those rules are going to go away, and we don't want to pull the rug out from under somebody. So let's say we're giving somebody medication under COVID rules, and all of a sudden the COVID rules change. We don't want to say, oh, sorry, we're not going to give you that medicine anymore. That's not cool. So we decided to set this up outside of the COVID rules so that even when those go away, we're still able to do what we're doing. And unfortunately, testosterone is a controlled substance, and we can't prescribe it legally with the type of telehealth we do. The DHEA, however, works really well for most people. As I said earlier, it replaces testosterone really to normal, some maybe low normal, but normal female levels. It's if you're looking for a boost in the gym and you want to get big muscles, it's not going to probably do that for you. Then you really need, either testosterone or really high levels of DHEA. But that's not what we're about. And there are other ways to get that, but that's not something that we do. But I think that with the DHEA, for most people, it's sort of just enough to get that testosterone benefit without the risk, and it's a legal way and sustainable way that we can do it and keep treating our patients.
Christina said, I've started growing facial hair with the HRT treatment. Will the HRT treatment help minimize them?
It might. It sort of depends on why you're growing the facial hair. So some women, that's part of the symptoms of the menopause transition, and if that's the issue, then this may help with that. There are other reasons that women have facial hair, and this, if it's some other reason, this may not help. But it can be beneficial for some women. So it's sort of one of these wait and sees. Yes, for some people it does. It's not something I'm going to go out and say, yeah, almost everyone this fixes it, because some it does, some it doesn't. Ultimately, laser hair removal is really the best way to deal with dark, with facial hair, unwanted facial hair. It's kind of expensive, but it does work, and it's a sort of pretty much permanent solution. But it may help. But again, I don't want to promise things I can't deliver. I try to be a straight shooter about what we do and don't do, and why we do it. And it may help, and for some women it does, but it may not.
Elizabeth said, can I take my multivitamin with my DHEA?
Absolutely. So yeah, with the hormones, whether cream pill or patch, multivitamins are totally fine and appropriate to take with all of the medication.
Nisha said, hey, I've only been on the cream and DHEA pills for a week now, and my cycle has started, but no other side effects. Is this normal?
Yeah, the first month can mess up the menstrual cycle for some women, and that's not unusual. For most people it doesn't, but it does for some people. Once you get past that first month, you should get back to normal. And if this continues to be abnormal past that first month, that's something that your doctor, me, or whoever is taking care of you really needs to know about. So we can, either adjust it or talk about evaluating it. But that first month, sometimes it can throw the cycle off.
Melanie said, will most symptoms subside around the same time, or will some symptoms take longer than others?
Yeah, some symptoms take longer than others. So for most, this is big generalizations now because not everybody's this way. But for most people, hot flashes and sleep issues tend to be early winners. Maybe not 100%, but in the first few weeks, you start feeling some benefit there. But things like skin improvement, hair changes, weight loss, even some of the vaginal changes, those can take a lot longer. By 3 months, most people are getting improvement, if not completely, pretty close to it, but are feeling, much better in almost all their categories. And that's the point. At that time, we do a check-in at about 10 weeks after you start the medication, that we would consider adjusting the medication if necessary, if you're not getting improvement. But yeah, it's not sort of a slight switch and an all or nothing. It's a slow, gradual improvement, and there's different things on different time frames, and there's physiologic reasons for that. But like I said, the hot flushes, night sweats, some of the sleep issues tend to be early winners. But again, the weight loss, vaginal symptoms, skin, hair changes, they can take longer.
Amy asked, is there any lab testing that you check periodically?
No, and that's one of the great things about hormone replacement therapy and telehealth. So this is one of these things in medicine that doesn't require lab tests and doesn't really require a physical exam. There are some certain things. We had somebody ask a question earlier about clitoral atrophy that may do better with a physical exam. But for the most part, for general perimenopause, menopause symptoms, it doesn't require really an exam, and it doesn't require lab work. There have been lots of articles written about this, sort of begging doctors to stop doing lab work for hormone replacement therapy. It's useless. It doesn't help. It doesn't contribute anything, and it just costs the patients time and money. The hormone levels vary all over the place throughout the month, from day to day, even throughout the day. And so, it can be low 1 minute and high the next minute. And a lot of these tests, particularly some of these mail-in tests, particularly the saliva tests, are very inaccurate. I had someone who did a saliva test who had surgical menopause. She didn't have ovaries. She had no way of producing progesterone. She wasn't being given progesterone, and the saliva test had her progesterone way too high. It's like, well, that's clearly not right. So the tests aren't very accurate. They're not really very helpful. In fact, they're pretty much not helpful as far as guiding even the starting dose or changing the dosage or which hormones to use for HRT. It's really all symptom driven. It's listening to your body. What your body is going to tell us what you need, and we're going to let your symptoms and let your body be the guide, and I can adjust you and adjust you based on what your body's telling you.
Christina asked if you start taking HRT or DHEA prior to 60, is it safe to continue after that?
Yes, it absolutely is. So it's a funny thing. So 60 is this sort of magic number, and it's really a statistical thing. And it really has most to do with cardiovascular issues. And so hormone replacement therapy is going to protect you from developing cardiovascular issues. But the problem is if you haven't been on it for long enough, there may be these underlying cardiovascular issues developing, and then all of a sudden giving you HRT with these unknown underlying cardiovascular issues can cause a problem. And so that's why starting somebody for the first time after 60, we worry that may be going on. And statistically, we know that if we do that, there's an increased risk of cardiovascular events in the first 2 years, and it's about 7 per 10,000. So it's not huge, but it's still enough that you don't want that kind of problem. The interesting thing is, after 2 years, those risks go away, and now you're back to the same as anybody else. And so, if you start the HRT before 60, the theory is that you haven't built up now those cardiovascular problems because you've been protected by the HRT. You don't get that same initial increase that you would if we started you for the first time after 60. And so you're back to that person. So let's say that we threw caution to the wind and we started you on HRT at 65 and you got through those first 2 years without a problem. Well, you're now back at the same risk as anybody else. And so if you've already been on it, when you hit 60, you can stay on it because your risk is the same as everybody else. So 60 is only a magic number for initially starting HRT. It's not really an important age for continuing HRT. And it's really safe to stay on hormone replacement therapy as long as you need it for symptom control. And so, for some people, they only need it for a few years. For other people, they need it for a longer period of time, and everybody's different. But it's certainly safe to stay on after 60 if you've been on it already.
Mary said, I am 50 and still getting a period, however irregular. Some months my period is regular, every 28 to 30 days. Other months it's every 3 weeks. How do I manage this with HRT? My moods are terrible and lots of depression, anxiety, plus weight gain. My doctor said it's the worst time in a woman's life, brutal, and gave me a prescription for an antidepressant.
It shouldn't be the worst time of your life. Unfortunately, that's an attitude that I disagree with. This should be a wonderful time of your life. I mean, this is, I'm that age. How old am I? I'm 58. I'm having a great time. This has been a really good time. My kids are starting to transition out of the house. We're able to do a little bit more. Life is good. And life should be good for you as well. The periods. So the thing about HRT that confuses people, especially people that are used to taking birth control pills, is it's very different from birth control pills as far as how it works with the menstrual cycle. Unlike birth control pills, you don't have to time this around your cycle. You're not going to stop it during your cycle. You're going to take your HRT every day, no matter what your periods do. And so it doesn't matter if your periods are irregular. It doesn't change the way you use your HRT. The HRT will still work. HRT isn't really designed to fix your abnormal periods. It does tend to improve them somewhat, but that's not really the primary sort of design of this. And so your periods are probably going to be about what they already were. They shouldn't get worse with HRT, although honestly, your periods are going to change whether you have HRT or not, and eventually go away. But you don't have to worry. You just take your HRT every day. Don't worry about your periods due. And it's still going to improve your life. And instead of making this the worst time in a woman's life, it should make it a really good time. It's actually a nice age.
Amy is asking if you're hiring NPs.
So we are not right now. We are we're right now we're just using board certified physicians, obstetricians, and some family docs. That certainly could change as we grow, but right now that's what we're using.
Indira said, I am currently on Metformin. Are there any reactive side effects with an HRT?
No, Metformin is safe to take with HRT, and the HRT won't negatively interact with Metformin. The Metformin won't negatively interact with HRT. Totally reasonable to take them together.
Ellen asked, my doctor PCP mentioned using IUD for progesterone and says it causes breast cancer. Otherwise, can you address this?
So IUDs for progesterone is fine. We sort of talked about that earlier. And again, it has to do with the comfort level, whether your Winona doctor is going to be comfortable counting that as your progesterone. But your doctor's not wrong, is it's a reasonable way to use progesterone. However, the progesterone in the IUD is a very, very low dose. It's enough to protect the lining of the uterus, but it's not going to give you some of the progesterone benefits, like the mood stabilization and the sleep benefits that the cream or the pills will do. The breast cancer issue is this sort of bugaboo that's out there. That's just it's one of these like holdover things. So there was a really interesting finding with breast cancer and hormone replacement therapy. The risk of breast cancer, the increased risk of breast cancer, is very small with hormone replacement therapy, almost insignificant, but not quite. And it turns out that women that still have their uterus that require estrogen and progesterone have a slightly increased risk of breast cancer. The interesting part is that women that just took estrogen did not have that same increased risk. And so most people think that it's probably the progesterone that's causing the problem, although honestly, it's never really made a lot of sense to me. And I think it may be a difference in the patient population in women that have had hysterectomies versus women that haven't. But that being aside, that's what the data says. However, HRT also gives you a decreased risk of cardiovascular events. You have a decreased risk of colon cancer. You have a decreased risk of endometrial cancer if you do it right. You have a probably decreased risk of ovarian cancer. So it gives you all these other benefits. And so if you look at a woman on hormone replacement therapy versus a woman who's never had it, the woman that's on hormone replacement therapy is going to live on average a longer life and a healthier life than a woman who's never been on it. So even if you have that slight increased risk of breast cancer, you have a decreased risk of everything else. So you have a better chance of living a longer, healthier life. So I think it's sort of it's unfortunate that people do this and they carve out this one little thing and scare people with it when that risk is actually very small. And overall, your other risks are so lowered that you're more likely to live a long and healthy life. So that being said, the IUD for progesterone is a reasonable way to do it, but it's also reasonable to use the combined cream with estrogen and progesterone or use a pill, are all safe and effective ways of doing HRT.
Jennifer said, thank you for making this available to women and being so responsive to all our questions. I'm almost done with my first month. My migraines and brain fog have cut back considerably. That reason alone has changed my life lately. Ready to tackle the rest of the issues with a clear head. Thanks a billion.
I'm glad to hear that.
Jonna said the HRT threw me into Hashimoto's, so I had to stop.
So the Hashimoto's was probably going to happen anyway, in my opinion. It's probably a red herring. It's probably a coincidence. However, the Hashimoto's needs to get under control. But once the thyroid's controlled, then it would be safe to restart your HRT. So you do need to concentrate on the Hashimoto's, but once that's sort of controlled and fixed, then it would be safe to restart the HRT if you'd like.
Okay, you're getting a lot of thank yous from Elizabeth, from Christina, from Ellen. Mary's asking, what is your take on BCP as HRT?
Don't know what you're referring to. I'm sorry. BCP. Can you type out?
Mary, could you type out BCP?
Sorry, I was up all night at last night. I did work a 24-hour shift last night. Oh, birth control pills. Oh, okay, great. Yeah, that's a really good. That's a really good question. Sorry. Yeah, we usually, OCPs is usually the way that we abbreviate that, but now I can see birth control pill, absolutely. My bad. So here's the problem with birth control pills. Birth control pills, in general, depending on which one you're on, but in general contain a combination of estrogen and progesterone, just like hormone replacement therapy does. Birth control pills, though, are very different. First of all birth control pills use synthetic versions of estrogen and progesterone. The estrogen is almost always ethinyl estradiol. The progesterone has a million different progesterones. And this is the way drug companies sell their pills, because all the progesterones, they're actually not even progesterones, they're technically progestins. Progesterone is actually a specific meaning of bioidentical progestin or progesterone. Progestin is the synthetic progesterone. So technically it's a progestin, not a progesterone. But anyway, the progesterone in the pill, the progestin in the pill, is what sort of separates these pills. And so all the drug companies that come up with their own unique progestin, and they tell you, oh, it doesn't have this side effect like this other guy's pill has, because all the progestins have these side effects. And the reason is that although they do work similar to progesterone, they don't work perfectly. And the analogy that people use, there's something called hormone receptors. And these are these biochemical structures that recognize the hormone. The hormone binds to these structures, and then that sends a signal to the brain and has the brain do what it's supposed to do when under the influence of these hormones. The problem with the synthetic hormones is they don't match those receptors perfectly. And in fact, there have been some drugs that have been specifically designed for this. So there are drugs that specifically bind to these receptors but don't do anything. And what they do is they block the real hormone from making these receptors work. But in any case, these synthetic progestins and estrogens, they have some qualities of estrogen and progesterone, but not all the exact same qualities as bioidentical hormones, or the actual hormones that your body makes. And so they don't work as well for what they're supposed to do, and they have side effects. The story I like to tell about this, so I used to drive up, when I was in college, I drove this beat up old Datsun B210. And my best friend, he had this like really hot Datsun 240Z, if you remember those. So the funny part was my Datsun B210 key would open the door of his Datsun 240Z. And so I used to tease him, Datsun's a Datsun. However, it wasn't good enough to start his car. Okay, and that's sort of the way these synthetic hormones work. They're good enough to give you some effect, but they don't give you all the effect. And so the birth control pills will give you some of the benefits of hormone replacement therapy, but they don't give you all the benefits. So that's the first part of it. So these bioidentical hormones, they're the exact absolute same hormone that your body makes. And so when they hit on these receptors, they do exactly what those receptors are supposed to do. And they're identical, they're bioidentical, they're the exact same thing that your body makes, and they work exactly the same way. So they don't have the side effects of the synthetic hormones, and they have more of the benefits, of the same benefits that your normal hormones have. The other part is dosage. So the way birth control pills work is they basically completely shut down the ovary so that the ovary doesn't ovulate. And then they completely take over the hormonal control of your body. And that's why with birth control pills, there's a certain amount of real pills and a certain amount of placebo pills, because that mimics the cycle so that you have periods. And that's how birth control pills work. Hormone replacement therapy doesn't do that. It doesn't completely shut the ovary down. So it allows the ovary to still make what it's going to make, and then it comes in and supplements that. So you still have all your natural hormones from your ovaries, and then you get additional hormones that are identical to the natural hormones your ovaries are making to supplement what your hormones are no longer making. And so it's a lot cleaner, a lot more efficient. It's a lot better way of giving back the hormones that you need, rather than what birth control pills do, which is basically wipe out what you are making and then replace it with something that's not as good. So instead, we're allowing the ovary to make what it does make, and then we're adding back some of what it already makes to supplement what it's missing. If that makes sense. And so birth control pills, I've always thought of it as a really lazy way for doctors to give hormone replacement therapy. There was a doctor I talked to maybe a month or two ago. Oh, I just give them birth control pills until they're 55, and then they never know, I'm like, that's a really lazy way of doing it. It kind of works, but it's certainly not the best way to do it, and it's not going to be as effective, and it's going to have a lot more side effects. So bioidentical hormone, true hormone replacement therapy is going to work a lot better than birth control pills.
Our final question is from Carmen. Are the estrogen pills better than the cream? I have heard the cream isn't reliable when it comes to consistent dosing.
Great question. And the answer is, for most people, they both work well. The cream is as reliable as the pharmacy it comes from. And as I touched earlier, our pharmacy is very, very reliable. So your cream is going to be consistent from one dispense to the next. You're going to get the same amount of hormone. And for most people, the creams work really well. And for most people, the pills work really well. I've had, and again, this goes back to that unique nature of the human body. I have had patients that they're on the cream, it doesn't seem to work very well. We switch them over to the pills, and all of a sudden it works better. And I have had people on pills, and it doesn't seem to work very well, and I switch them over to cream, and it seems to work better. No good reason for that, but it's just, again, every body is unique. So for most people, they're both excellent choices, and they work just fine either way. And so it comes down to what's more convenient, and what fits best with your lifestyle, your pocketbook, and whatnot. There are some theoretical reasons why the cream is a little bit safer. There's something called first pass metabolism, so it's a little gentler on the liver, a little gentler on your lipid profile, a little bit lower risk of blood clot. But for most women, that risk is, that difference is small enough that it's not really a make or break thing. But for the average person, they both work well. And for some unique people, sometimes one works better than the other for some reason that I don't think anyone can really explain.
Okay, that is our final question tonight. So thank you, ladies. Thank you, Dr. Green. We have these each month. So if you had a question that didn't get answered, you can come to next month's live webinar.
And you can message me or message your Winona doctor. We're very happy to address your questions and issues online. That's what we're here for. And we like a well-educated patient is a more compliant and a happier patient. So again, we want to answer your questions and make sure you're comfortable with what we're doing. Thanks, Liv. I appreciate your help tonight.
Oh, thank you. Well, we will see all of you maybe next month. So thank you, everyone.
All right, see you guys.
Bye.